All righty.
So thank you for joining us for the companion recording on our Pragmatic trial, evaluating a complex intervention for managing treatment-related toxicity proactively among women with breast cancer and chemotherapy. This recording covers some of the practical considerations and trial insights using the curriculum wheel to guide our presentation. My name is Monica Krzyzanowska, and I am a medical oncologist in Toronto, as well as a professor of medicine at the University of Toronto.
I'm Melanie Powitz, and I'm the scientific director for the Cancer Quality Lab at Princess Margaret Cancer Center and an assistant professor at University of Toronto.
For those of you interested in more details regarding our trial, the final report of the trial was published in the British Medical Journal in December 2021. You are likely familiar with the curriculum wheel for pragmatic trials being used in this training program. I will kick us off with some of the parts of the wheel and then turn over to Melanie to talk about some of the more distal aspects. So let's start with the intent and question for our trial. As you heard in the companion video, the problem we were trying to solve with this intervention is the high rates of emergency room visits and hospitalizations among patients with cancer receiving chemotherapy. In our previous work, we quantified the problem using population-based data. Our theory was that if we could identify symptoms or toxicities early before they get out of control, we could potentially prevent the patients from presenting to the emergency department or being hospitalized. We decided to focus on women with early stage breast cancer, as breast cancer is a common type of malignancy, and we had data on healthcare utilization, specifically emergency room visits and hospitalizations in this particular patient population. And the specific question that we asked is whether proactive, nurse-led, telephone-based management of treatment toxicities could keep patients out of the emergency room or being hospitalized. So we initially did a 2-center pilot to sort out the logistics of delivering the intervention, then moved on to a 20-center cluster randomized trial. As you can imagine, with 20 centers participating, they were not all the same. To try to balance center characteristics between intervention and control arms, there were several historical variables that our study statistician used in the randomization in something called a covariate constrained randomization. These variables included patient volume, historical rate of acute care visits in the population of interest at the particular center, as well as rurality. The statistician came up with many different center combinations that balanced these variables, and we then randomly picked one of these schema, then randomized one set of centers to the intervention and one to control. So our primary outcome for the study was acute care visit rate, and we evaluated this using administrative data available through ICES. And in the companion video, I go through exactly how we did this. And the reason we decided to focus on emergency visits and hospitalizations, as opposed to, for example, symptom control as the primary outcome, is that there was already a signal in the literature that this type of intervention can improve patient symptoms. But funders, healthcare funders, are not keen on paying for these types of interventions just on the basis of improved symptom control. So what we were hoping for is that if we could show that this intervention also positively impacts the health system, funding could be theoretically redirected towards paying for nurses to proactively monitor patients during chemotherapy. Also, doing this trial and evaluating the primary outcome using administrative data substantially decreased the costs with running a trial and collecting that amount of data. And lastly, it allowed smaller centers to participate, as many small centers would not be otherwise able to participate due to the challenges associated with collection of data and hence increasing generalizability. So while our primary outcome was acute care utilization, we also had a number of secondary outcomes, which were more traditional outcomes in these types of studies, including implementation outcomes such as fidelity and adherence, and what are called in the Proctor framework client outcomes such as quality of life and symptom control. So for our trial, we introduced the intervention in the intervention centers as a quality improvement project. So 10 out of the 20 participating centers introduced this intervention as a quality improvement initiative. We worked with each of the teams to create implementation plans that took into account local context. We gave flexibility to the centers for the intervention nurses, and ideally they were from routine care practice. Overall, based on 2,158 patients were included in the study, and a subset of these patients, approximately 561 patients, completed the patient-reported outcome that we collected throughout the study duration. And also at the end, we conducted qualitative interviews with physicians, nurses, and senior leadership to further understand their experience with implementing and delivering this intervention. And I'm going to turn over to Melanie now to talk about some of the other practical considerations with running this trial.
Great. Right. So we published the statistics analysis plan in a methods paper if anyone is interested. But the study included all comers to the cancer center who met the eligibility criteria within the intervention period. We started collecting data on outcomes following a 30-day run-in period at the beginning of the study to allow centers to work out some of the kinks of implementing the intervention at their sites, particularly around identifying eligible patients and delivering the intervention. As Monica mentioned, the primary outcome was the cluster level mean number of emergency room visits and hospitalizations per patient for the at-risk period, which was the start of chemo to the end of chemo plus 30 days. And it was measured using routinely collected administrative data at ISIS. One of the issues was that we couldn't discern who had received the intervention and what dose of the intervention they had received, since we were using the administrative data and patients were not individually consented to the study. We could also not necessarily always tell which satellite center or institution a patient was seen at, particularly for centers where multiple hospitals had amalgamated, such as Ottawa or Trillium Health Partners. The secondary outcomes, which included implementation outcomes, self-efficacy, symptom severity, were collected from a subset of patients. The patients were consecutive patients following the run-in period, who also individually consented to the PRO data being linked to data at ISIS to look at the primary outcome. One of the challenges was that the statistician was located at OCOG and had access to ISIS data through their portal, which can cause issues with the release of patient-level data needed to actually run the analysis. When it came to ethics, consent, and regulations, we used centralized ethics for Ontario, which greatly streamlined the approval and the startup process, since 18 of the 20 participating centers were involved in the centralized ethics approval process. Additionally, there's a standardized contract template for Toronto area hospitals, which really reduced the administrative burden of study startup since it streamlined the contracts process. One issue was with navigating data sharing agreements to allow for the import and linkage of some of the primary data from the PROs to the ISIS data holdings. That was both challenging and time consuming. And we also had to bring in ESAS data from the Cancer Care Ontario, since it wasn't an available ISIS data holding at the time of the study, and we had to navigate the data sharing process with them. Patients opted out of receiving the intervention rather than opting in. There was no individual consent except for the subset of patients who were participating in the PROs. For study materials, we used scannable paper booklets to collect the questionnaires to reduce the administrative burden of transcribing the PROs into a study database. Digital literacy was an issue amongst some of the intervention nurses. So we needed a very user-friendly way of tracking which patients were on the intervention and when they needed to receive the intervention calls. So we used a macro-enabled Excel tracker that projected what call dates the patients would need once they were enrolled and when their chemo start date was added. And this automatically highlighted patients that needed called on any given day. There were several partnerships that helped support this project. The pilot work was completed in partnership with Cancer Care Ontario, and the study was funded by the Ontario Institute of Cancer Research and completed in collaboration with Cancer Care Ontario. We also partnered with the oncology OCOG group as a contract research organization to help provide central project coordination for the trial and to manage the subcontracts with each of the centers as well as the site payments on our behalf. For quality control and oversight, unlike clinical drug trials where the intervention either works or it doesn't, the behavioral interventions are largely dependent on buy-in from the participating centers, as well as the quality of the intervention can be impacted by how it's implemented at the site. So we hosted monthly check-in calls with each of the participating centers to create a community of practice and to share and troubleshoot issues with delivering the intervention. Some of the major issues that we had to troubleshoot were capacity to deliver the intervention, particularly once the number of patients who were enrolled on the intervention grew. Issues with communicating findings from the calls with patients back to the regular team of care to close the loop. And also questions about responsibility or ownership, who owned follow-up actions that needed to be done on behalf of patients, such as arranging for referrals or arranging for home care. For data, this study was unique in that it used routinely collected administrative data from ICES to evaluate the primary outcome, which greatly reduced the administrative burden on the centers that were participating in the study. For inclusion, diversity, equity, and accessibility, many remote monitoring interventions to date require the use of a specific app or a specific device, which can exacerbate existing disparities in care. This intervention focused on delivering via telephone, which is considered the most equitable way to do so. Due to issues with administrative burden and lack of clinical trials infrastructure, many of the smaller community-based centers don't normally get to participate in clinical trials. And so the pragmatic nature of this study and lack of primary data collection or management allowed us to offer the intervention at centers, which would normally be left out of studies. For financing and resources, there was a need to buy out the time of nurses to deliver the intervention within each of the participating centers, and this was ultimately one of the largest expenses for the trial. And there's also a need for coordinating contracts, payment, data collection, and ethics across each of the 20 centers, which is a significant undertaking. And so our other largest expense was related to central project management for the trial.
So this maybe gives everyone a little bit of insight into some of the practical considerations that or things that we did with respect to our trial. Obviously, there's many other things that we did day to day. So I do hope that between this video and the other video describing the trial in more detail, this gives you a bit of an idea about how these pragmatic trials are done. And obviously, our team would be happy to answer any questions by email as you're going through your learning. So thanks very much for your attention.